and show you how my research has informed even my community involvement, but also has an impact on the way that I teach and work with students, really on all levels. So I'm a qualitative researcher. I do see value in quantitative research. I don't want you to think I'm anti-quantitative, but I'm interested in knowing what are the stories behind the numbers. And that is really what led me on my journey into understanding Black maternal health and working towards, maternal health equity. So I have a Black feminist approach. I'm also community-based participatory research, because I feel that for us to eliminate racial disparities, we really have to understand the communities that we work with. Our history is very important. Right now, in looking at how to address the maternal health crisis, I'm going back in history at a time when, for Black women, there was segregation, there was poverty, there was violence, racial violence. And the alarming thing is that maternal health outcomes were better for us then than they are now. So I'm into going back in history to see what was done to keep women safe during this time, what was done that could be used today. And storytelling is an important part, but also artistic expression. So the artwork that you see is art that came from my dissertation research, but also art that I use to really uplift Black maternal health. So my research centers on the voices of Black women. That's just my focus of my research. I understand that not everyone identifies as being female or wants to label female woman. But I just want to acknowledge that my research comes from learning from their experiences, and I'm just very careful in how I present my research. I do feel that if we improve the healthcare of Black women, everyone is going to benefit. And there are some things in the approach that can help you when you work with different populations. But I just want to make sure I'm not misrepresenting, saying that this is the same for someone who is a transgender male who's giving birth. I still think there's some intersections, but I don't want to say this is the same experience for everyone. And also the maternal health crisis is impacting everyone in the United States. And Indigenous populations, I'm going to show you some statistics of what I have right now, but also we have to keep an eye on what's happening in Hispanic birthing people as well. Okay. And we all know, most of us know that there is something going on in the United States. And this is from 2021, and you see how there is a sharp increase. Although we're talking about maternal health, the numbers continue to rise. And it's alarming how we compare with other countries. This is alarming, not only looking at our overall maternal mortality rates, but what's happening in the Black community. And this is from 2021, so the numbers have increased even further. And you will see on this next chart is that the numbers continue to rise in sharp increases. One thing that you will see missing is the maternal mortality rates for Native Americans. And it's really, for me, I'm worried because I'm wondering why we're not seeing the statistics yet, but I'm also worried that the numbers may surpass Black women, Black birthing people. But I also want you to look at the Hispanic, the light blue. And as you will see that Hispanic women have always historically been lower than white women. And you will see they have a very sharp increase. And for the first time, look at 2021, for the first time in like 20 years, they're surpassing white women in maternal mortality rates. They're still low compared to Indigenous and Black women, but keep in mind that that's still very significant. And if we're looking at prevention, we have to really understand why those numbers are happening. And my focus on Black maternal health came out of really trying to just understand maternal mortality in the US. And as a Black nurse midwife, I was even unaware of how significant the disparities were. And it was through my own research, not only to find that Black women were disproportionately impacted, but what they were saying placed us at risk didn't make sense to me, because I was told that Black women were poor. We didn't take care of ourselves. Even had a colleague said, oh, they have a bunch of diseases. And I'm like, but that's not the Black women that I know. And I've cared for women who live way below the poverty line, and still through their care, and also I should say how they care for themselves, they still had good health outcomes. And I wish from my very early experience in working with adolescents and working within the community that I kept those statistics on the work, because it just told me that there's a way to provide care so that we can have good health outcomes. But learning that 80%, and some parts of this country is even as high as 90%, in Connecticut and also in Massachusetts, is up to 90% of the deaths could have been prevented if one thing was done. Their death could have been prevented. So again, it's very alarming to learn this, and that started my journey to try to understand. And when we look at, and this is again why I focus on Black women, and I want to uplift Black women and the health and the care that we provide to them, is because when you look at anything related to maternal and infant health, we're disproportionately impacted. 3 to 4 times more likely to die during childbirth, twice as likely to experience severe complications, twice as likely to experience infertility, twice as likely in some parts of this country, 3 to 4 times more likely to experience perinatal loss. And that includes miscarriage, stillbirth, premature delivery, and having the baby not even make it to 28 days of birth. But also even learning that women who receive infertility treatment, Black women who receive infertility treatment, and it's also very significant among Hispanic women as well, they're more likely to have a fetal loss, have an infant death. So this is really my research is really trying to understand why that's happening. And some of the factors, we know that racism is a risk factor, and people are still trying to understand how that shows up. Weathering is one way. It's just saying that chronic stress related to racism places us at risk because it ages our bodies. And so there's still research, again, to really understand what that is like. And people don't really even understand the full impact of racism. A lot of people think that it's a one-time incident, or something happened on a personal level, but not realizing that as a person racialized in this country, every moment you're impacted by racism. Whether you're driving in your car and you're afraid you're going to get pulled over, if you're in the store and you have somebody following you around the store, or someone checking, you're paying for something with a credit card and they're wondering if it's stolen. So, and those are just some of the examples, but can you imagine dealing with that on a daily basis? It's like you make it through one day and then you have to wake up again the next day and deal with it all over again. And a lot of times we don't even see it coming. We're impacted in a part of a situation that we didn't even know. But just imagine if someone's experiencing that and then they're pregnant now, and pregnancy doesn't say, oh, you're pregnant, we're going to take it easy on you. I feel that in this country, we actually put more on our women who are pregnant. And even just think about after someone delivers, how many of us have the luxury to stay out of work and for how long? So just some examples about how pregnancy doesn't mean that things are going to be easier for us. So, but understanding the social determinants of health and how that shows up. But also, it's not so much prenatal care, because you'll see women starting prenatal care at 6 weeks and still having complications or dying during childbirth. So it's not only prenatal care or starting care early, it's about getting quality care and having lack of diversity in healthcare providers. Some of us live in communities, we have no choice. We don't see anyone who looks like us. But how does that have an impact on our care? And that's something that I'll talk about later. And also, I just also forgot to mention that I'll have time for questions and discussions. But really, there's no clear way of really understanding how do we address all of this in those we care for. Not to say it can't happen, but as long as healthcare providers, I think it's important for us to have an understanding of what impacts those communities we care for. So if your community is predominantly people of color, what do you know about those communities? What do you know about things they don't have control over? Another, for me, a scary piece is the structural aspects of it, the systemic aspects of it, and how as healthcare providers are we contributing to that? One quick way to do a check is what policies and procedures do I have at my institution that end up causing harm to those we care for? And just a question to think about. So my work came out of my dissertation research, and I'm going to talk about a few other studies that I'm doing right now. But when I first started looking into Black maternal health, and I started looking at the literature, what was published, first I have to say, and this is about 2015, nursing was doing very little in researching and understanding the childbirth experience of Black women. It was like basically non-existent. I was a student, I'm telling you now, because of my experience doing lit reviews, you give me any topic, I could find you some articles because I had to really learn how to search. And I searched over 2,000, 3,000 articles and only found 3 related to nursing that looked at the childbirth experience of Black women, only 3. But I found several articles from all disciplines that looked at the statistics and would say, oh, by the way, Black women are 4 times higher than everyone else, or Black women have the most significant maternal deaths. But there was no reasoning why. And a big piece that was missing was nobody was talking to Black women. You can talk to Black women, you could talk to me, I'll talk with you. But from my study, I learned that Black women do want to do research. They just want to make sure that they're safe in the process, and they want to know, where is this information going to land? What are you going to do with it? And is this going to help other people? And so in my study, I interviewed 9 women who had severe life-threatening complications during childbirth and postpartum. Some of them had 1 experience and some had 2. And so there were a total of 13 experiences. And these, I want everyone to understand, these were not that, oh, my blood pressure was just elevated. It was that my blood pressure was up and my kidney, my liver was impacted, that I didn't even know if I was going to survive. And so the themes that came out of my study was the level of knowledge and what these women understood about complications. Several of them were blindsided by their diagnosis. Women were diagnosed, the leading one was preeclampsia, and we had cardiomyopathy, postpartum hemorrhage, antepartum hemorrhage, sepsis. Those were the conditions that these women didn't know anything about their condition until they were actually diagnosed, and they didn't learn the severity of their condition. One woman, she was having chest pain, went to be seen and was told that she was having just a little angina. And this is someone who delivered 10 or 11 months prior, and noticed that since she gave birth, she was having these symptoms. And so when she was told that, oh, this is normal, she realized that she was having symptoms of cardiovascular disease, and she learned that this was a leading cause for women, a leading cause of death. So, but she didn't know anything about, she didn't realize she was having the symptoms because she didn't know anything about it. The other was preeclampsia, women who had severe headaches. And there was one in particular who was actually driving around and just thought it was from her being tired, didn't hear anything about preeclampsia. And what she did know, she said, oh, I had an aunt that had it, but I just thought it was swelling of the feet. And that was a common thing that the women who had preeclampsia told me. Oh, I thought it was just your feet swell. I didn't realize it impacted my liver and kidneys. So the level of knowledge impacted how soon they went in for care, but it also impacted their ability to advocate for themselves. When they were having severe symptoms and someone's like, oh, no, you're fine. They didn't know how to advocate because they said, well, my provider said I'm fine. So, I'm fine. And then it was later they realized how severe their symptoms were. Another important thing was their relationship with healthcare providers. This was something that was so important throughout in how they even view their experience of care. Some women felt, I would say like 1/3 felt safe and well cared for, 1/3 felt like they were part of someone's routine, and 1/3 had a combination of both. So those who felt safe and well cared for said that their providers had compassion, that they kept them informed, they trusted them, and they felt like they were looking out for their health and well-being. And even though they had these life-threatening situations, they still looked back positively on their relationship that they had with their nurses and their providers. 1/3 said that they felt they were part of someone's routine. You go in, you ask their pain scale, you do your vitals, and then you're gone. No compassion at all in the care. And even when they felt that there was something going on with them and they just wanted a little compassion, they felt that it wasn't even seen or heard. One young lady went to the bathroom. She just delivered, 9-pound baby, vaginal birth. Everything was good. Went to the bathroom, said that she started bleeding. She thought it was urine, but it was pouring out of her. She said it sounded like someone pouring a gallon of milk in the toilet. She was bleeding so heavy. She called for help. They came and they helped her. She passed out. She woke up in the middle of the night. And the nurse was like, "Oh, you made it." And she was like, "What happened?" And she said, "Well, I was told I had a hemorrhage. I didn't know what that meant, but that I had to get 3 units of blood." And so her first question was, "Did anyone call my mother?" And now, mind you, she was in the hospital alone. And her nurse told her, "You could call your mother when you feel up to it." And she was like, "If I was in a life-threatening situation and you knew that, my mom is the most important thing to me, she should have been called." So she just wished that there was some compassion in her care, and even left the hospital early against medical advice, because she was like, "I felt like I wasn't really, the physical things were cared for, but I have family that could do that for me at home. At least at home, I could be surrounded by love." So again, when women miss that compassion in their care, they were more likely to complain about racism. And that brings me to my next theme, is that race does matter. Even those that had a good experience still felt like showing up as a Black woman dictated how they were treated in their care. The woman who came in who had the chest pains, and it was told that it was normal, as a little angina, was almost discharged. She actually was discharged, had her papers in her hand, and as she was leaving, another provider came into the room and said, "No, we can't have you go home yet. We need to do more tests." And she said to me, "I don't know where he came from. I think my nurse went and got him," because she knew that something was wrong. So when they further evaluated her, she had cardiomyopathy. And they told her if she didn't improve in 3 months, she would need a new heart. And her first thing was, who would give a Black woman a heart? But she also felt that if I would have went home and rested, I wouldn't be talking to you today. So she feels like because of her race, that people assume that she exaggerated her symptoms. So just again, people were aware of that, not only when they presented their symptoms, but also when it came to health education, where some were told about, like one woman said, "I was told about, food stamps and WIC. Nobody talked to me about the complications that could happen to me." And I know because they made an assumption that maybe I wouldn't have been able to understand. And that's only her belief. So the last two have to deal with mental health. Being faced with uncertainty, being told, the person who had cardiomyopathy, "We're going to do what we can to prolong your life." And she said, "I just gave birth. I thought about who's going to take care of my baby and my husband." Can you imagine that? Even one woman had preeclampsia, and she said, "They did everything and my blood pressure would not go down." And she was like, "I had one moment, I didn't know if I was going to make it. All I did, I had to just pray that I would be okay and my baby would be okay." So can you imagine to be faced with that when you're going in to give birth? When I ask anyone about childbirth, usually the first thing they say is pain. "I'm worried about pain." But nobody thinks about, I may go in and not come back out. So can you imagine what someone is experiencing when they go through that? And that brings me to my last one, is that their mental health and well-being was impacted by their experience. And several of them were still healing. They would say, "Oh, I'm in a better place, but I'm still healing from what happened to me." And I have to tell you that all the women in my study, no one had their mental health assessed. And no one even said, "Look, this is what you should do if, I'm sure you have questions. This may have an impact on you. If you're feeling a certain way, here's someone that you can talk to." They didn't have that. They relied mostly on their partners and their families for support. So again, just a quick overview of the study, because this really helped to inform what I do in the community. And I'm going to share that with you. So just knowing the need for health education, but knowing how important that relationship is to them. Most people who go in for care, they want a good relationship with their healthcare provider. And so it just makes me more aware. And I'm going to talk more about who is on the healthcare team, but also acknowledging that race, as much as we want to ignore it or say we're good here, we have to understand how race impacts the quality of healthcare that people receive. And then the last part is really considering whether someone has a complication or not, is really still assessing their mental health and well-being. And that should be for anyone really who is pregnant, because we know they need the support in that. And so for me to develop interventions to address maternal mortality, I have to talk to those who are most impacted. So over the summer, I did data collection where I interviewed 16 women who have experienced loss. This is miscarriage, ectopic pregnancy, stillbirth, and also a neonatal loss. And so they shared their experiences with me. And this is just some preliminary data as I'm going through. But again, that relationship with the healthcare provider is extremely important. And as we're thinking about what we can do, I have to share what one of the women shared with me. She had experienced 2 losses. And she said her OB, who ended up retiring, she said how he, an older white man, she said how after, he of course checked the physical parts of her and he said, "Do you have any questions?" And she was like, "I was so overwhelmed, I didn't know what to say." And he said, "I know you have some questions. I'm going to just sit here with you for a minute." She said how no one has ever done that for her, but it really felt empowering that she did have questions. And then when he was leaving, he said, "Is there anything else that I can do for you?" And again, she was like, "I didn't know what to say." And he's like, "I know there's something. I'm going to take a moment. I'm going to sit here with you until you let me know what can I do for you right now." And those 2 questions were life-changing for her. So again, I just want you to see, even though she went through something that did break her heart and her spirit, but to have her provider see her and ask her. And that's the other part that I'm learning, is that people want to be seen and heard. They know healthcare providers don't have magic and may not be able to change a bad health outcome, but still they can show up and listen. And so that was something that's coming out of this study, but also feeling like a priority, especially now in this day and age where we know we're in a maternal health crisis and we know who's disproportionately impacted. So you have someone who's Black that comes in, I'm not saying treat them like a disease, but treat them like they're a priority. And you want to make sure that even if everything is good, you want to show them that you're providing the best care that you can to them. And this last piece I just want to share is that every pregnancy means something. It may mean something differently to each of us, but to have one of the women in my study who had a loss at 6 weeks say, I asked if she had a connection. And she said, the moment that I felt like I was pregnant, that I knew I was pregnant, I had a connection. That when they told me that my baby wasn't viable, she said, I felt like I actually held the baby in my arms and the baby died. So just to say, because I often hear, "Oh, she's early, she's going to be fine," or you could get pregnant again, or, this is what you can do next time. Those are things that don't give them time to grieve and to acknowledge that I had a loss. And so I'm still working on that study, so I will be coming out with more information, but want to show you that how research can be, how I use research. And this is a mixed method study, and this is the research team that I'm working with at UMass Amherst. We're looking at transportation and how transportation impacts the experience of care, of prenatal care. And this is an interdisciplinary team, like Dr. Shannon Roberts. She's an engineer. Favari Iridacunda is in nursing with me, and Lindiwe Sebeko, she is public health. Nutrition is her focus. So together, we're looking at transportation, and outside of what we learned, this is our, we received a seed grant, but what we want to see is what can we do if we have a better understanding of transportation, what can we do to make sure that experience of care is improved? And I also take my research to talk to all members of the healthcare team. And just even want to clarify that. When we say healthcare team, we automatically go to nurses, to OBs, to other doctors. Well, we don't really look at anyone who comes in contact with a woman to provide, healthcare. And that starts with the front desk. Even calling for an appointment, women are made to feel a certain kind of way, especially when something is important to them. They're told, "Oh, you could wait till next week," or "We'll see you in a couple days." Even so, that first interaction sets the scene. And when you go in for your care, your visit, and you encounter that person at the front desk, even though you could be the best nurse in the world, the best provider, but if that person at the front desk devalues who they are, that person will take that with them as they go through every other visit. And they'll look at you and say, well, you must know what this person up front is doing. So anyone that comes in contact has an impact on the experience of care. So everyone needs to be aware, and everyone has to play a role in how we address racial disparities, how we improve healthcare. So we just have to keep in mind that I'll even tell you, there was a woman who was having a ruptured ectopic pregnancy, and the person who was drawing her blood, the phlebotomist, kept drawing the blood even though she passed out. So it didn't even take a moment to say, did call for help, but still want to get the blood. So that's why I say anyone who comes in contact with the patient has an important role in that experience of care. And those are medical residents there. And they also, we talked about history, we talked about racism in healthcare. And for some of them, this was their first time even thinking about this. I had one of the residents was waiting for me when I left, and he was like, we never talk about this. But he also said, you know, what you said is going to impact the way that I interact with my patients. And I just feel like we have to have more of these conversations so that we're more comfortable in talking about it. Nobody wants to talk about racism. It's challenging for all of us. We're all in different levels in our understanding. I've come in contact with people who've never talked about race or racism in their lives. They knew it was an issue, and there's a discomfort in that. But I find that when we talk about it, we're empowering and strengthening each other so that we're in a position to care for our patients. And a lot of times people ask me, how does racism show up in care? And so I just want to just go over a few things. And the common thing that I hear, whether I'm doing research or I'm just talking to people in the community, is not being acknowledged. To have someone go into a room and talk to you about your most personal, we know like our reproductive organs, our bodies are so private and sacred to us. And to have someone come in the room and not even acknowledge who you are, they don't even know your name. They don't even ask you how you're doing, or they ask you and before you answer, they're on to the next. So that was really something that's key that not only again has come out of my studies, but again, just talking with people in the community. And just having disrespect from any member of the healthcare team. And again, that's from the front desk, the person doing the vitals, you know, even the person coming into the room, just feeling disrespected. And this is the part that's the most alarming for me when I looked at maternal mortality. Because when I first started looking into this, the women were blamed. They were blamed for their circumstances. But to learn that someone goes in with a complaint and they're not properly evaluated, that someone doesn't even get a complete history from them, and they don't even do a physical assessment. And I'm talking about someone who even goes in with a headache. A standard of care is to do a blood pressure. Can you imagine someone not having a blood pressure done, someone not having their urine checked for protein, which are basic standards of care? And even though some things have changed in how we diagnose, for example, preeclampsia, you still have to get an accurate history and physical assessment. One thing I've learned as a nurse midwife is to never go in the room thinking you already know the answers without talking to the patient. And I can give you a quick example of that. Had a young lady that came in complaining of itching, vaginal itching, saying that she had maybe a yeast infection. And I always still want to question it. I also want to see who am I talking to and what's going on. And this person actually went in for care and was told she had she was told it was just a yeast infection. She wasn't even examined. When I went in the room and I talked to this patient, I examined her, she had an outbreak of herpes, a primary outbreak of herpes. So she was treated with an antifungal cream. But the person just listened to her symptoms and said, oh, this is what it is. So they didn't even bother to check her. So I'm saying it's just basic questions to ask your patient and a basic physical exam, and you could do those quickly. I know people often say, oh, we don't have enough time. But in this day and age, you have to find the time to properly assess. And you have to communicate with those that you care for. A common complaint is being misunderstood or judged by healthcare providers. And we already know that what's happening in our society and assumptions made by certain populations we care for. So when they come in, you don't want to be a part of that system. And when someone is misunderstood or judged, again, especially something so precious and related to their bodies, they're actually traumatized from that experience. And I know certain populations that don't go back for care. So again, this is how it shows up in the care that we provide. And this could prevent someone from receiving that quality health care that they need. And here are some actions, and I'm going to be really quick so we have time for questions and comments. But just some things to think about. Creating a space where people feel supported and heard. Focus on prevention. But when you focus on prevention, you don't want to go in and scare the person and say, like I had someone who was on baby aspirin, who's pregnant, and we know that studies have found that it decreases risk for preeclampsia. But she's coming to me with questions, and she's like, I asked my provider, he said, because I'm Black. And I'm like, it's more than you're not on baby aspirin because you're Black. This is what it does to the body. So I'm just saying that we can't treat our patients like they're a disease either. So we have to find that balance, but we have to make sure that people are given the tools to take care of themselves, but also we do our part as healthcare providers, focusing on the physical and mental well-being, but providing unconditional, non-judgmental support. That's the piece that's often missing. So regardless of where someone is coming from, provide them with the best possible care that you can. Because a lot of times we don't know those social determinants of health. We don't know what else is going on. But a lot of times if we are making someone feel like, oh, you should have did this, you should have done that, that's also taking away their power and taking away, causing harm to their experience. So we have to you have to be there for our patients regardless. And unfortunately, it happens for some, but it doesn't happen for others. So again, non-judgmental support, but also recognize that those we care for understand the issues and they know the solutions, and we have to work in partnership with them. So just to wrap up is just to say that as healthcare providers, we have to educate ourselves and be aware. Wherever community you're working with, be aware of what's happening. Be aware of why they're showing up at the time that they're showing up. But also think about, what do I need to do as a healthcare provider to make sure that they have a good experience? Because that's the other thing with statistics, is that people will say, oh, well, I have good health outcomes. But then when you talk to women about their experience, although they survived and the baby survived, they can tell you a different story about what they went through and the harm that they experienced to get to where they got to. Even recently, I talked to a woman who had a cesarean birth, and she said how I just chose a C-section because I wanted to get everything over with. Because of how I was being treated, I knew if I just had the baby, they would leave me alone. And that's unacceptable. And it's also, I had someone tell me, how come you healthcare providers can't be optimistic? How come you can't come into the room positive? You have to come in telling me all the things that are wrong with me or could go wrong. So anyways, I just think that we have to be aware of how we show up and that we can all have a role in that. And I'm just going to very quickly just let you know just about Lucinda's house, because I took my research and I want to provide education and support in the community. Being in the community also helps me see what it is that people need and their concerns. As my work, I'll do a presentation on childbirth, and I have people who will come up to me and ask about infertility, that will ask about perinatal loss. And some of you said, are you going to do a research study on that? So I would not have known that unless I worked in the community. So part of it is bringing resources that help to alleviate stress, that help provide health education and help people see the resources in the community. And this is a community baby shower. At this one in Hartford, we had 101 families come through. And our New Haven one, which we partnered with hospitals, we had 170 families come through. And people didn't come to just receive gifts. They came because they want the information. They just wanted the community. They want to see people show up for them. So that's how I use my research to help inform how I show up in the community, and so that I can have an impact in that way. So I'll stop there. I know I gave a lot of information. So I'll stop there and just open up for any questions.